The ability to bear children in most African societies are often not seen as a biological function, but also tied to identity, tied to family continuity, as well as social status. And as at now, a lot of couples are still battling and struggling with infertility across the continent. According to the World Health Organization, 1 out of 6 people are affected by infertility globally. And in Africa, this is crucial due to untreated infections, due to limited access to healthcare facilities, as well as societal stigma. You're welcome to another episode of Meet the Practitioners on HealthAfrik, brought to you by the Association of African Universities, AAU, and the Center for Pregnancy and Childbirth Education, CPACE. My name is Isabella Teta Hinakwa. On today's episode, we'll be discussing issues related to fertility and infertility. We'll get to know the medical as well as the lifestyle factors that are influencing it, and also more facts to be discussed. And I know you wouldn't want to miss this discussion. We'll go for a quick break. When we come back, I'll introduce our guest to you and start the discussion. Please stay tuned. You're welcome back from the break. This is Meet the Practitioners on HealthAfrik. You can follow the discussions on our social media handles at Association of African Universities, both on Facebook and YouTube. And today we are discussing topic of fertility as well as infertility. The aim is to inform, is to educate, as well as inspire conversations that promote understanding and also access to quality reproductive health care across Africa. And it's a privilege to have here with us Dr. Seth Hansen Garson, an OBGYN from the Kolebu Teaching Hospital. He's been with us a couple of times, and today he'll be helping us discuss fertility as well as infertility. Hello, Doc. You're welcome to Meet the Practitioners.
Yeah, thank you.
It's been a while, though.
Yes.
And good to see you again. Yeah. Today's topic is quite interesting. You know, when we talk about infertility as well as fertility, it's quite sensitive when you are discussing with people who are affected with it. Before we start the discussion, I would like you to briefly, you know, when we talk about fertility and infertility, it's somebody being able to give birth or not being able to give birth. But in the medical field or perspective, explain what it is to us.
Okay, thank you very much. So when we talk about infertility, in the medical point of view, infertility is inability of a couple to achieve a pregnancy.
Okay.
After 1 year or more of regular unprotected intercourse.
Okay.
And regular meaning that you are having intercourse at least 3 times a week.
Okay, 3 times a week. That's a regular.
Yes.
Okay. My next question is at what point do you consider somebody being infertile? But I think you mentioned, 1 year. Is after 1 year or?
Yes. So usually we use 1 year for the general population. So after 1 year or 12 months or more of unprotected regular intercourse, if there's no pregnancy, we define or we state that the person is having infertility. But when the woman is above 35, so that is when we initiate investigations. Okay. But sometimes we initiate investigations earlier. Okay. If the woman is about 35 years, we start investigation after 6 months. Okay. Okay. And then if the woman is 40 years, we initiate investigations immediately. The patient reports. Okay. And then also, if irrespective of the age, if the woman has some conditions, including amenorrhea, she's not been having her menses for some time, she's been diagnosed as having tubal problem, or as any other issue that is related to fertility, or even the man has been diagnosed of having low sperm count, or anything related to the sperm, then that one we start investigations immediately.
Okay. I'm happy you made mention of the men having low sperm count, because in Africa, in most of our homes and societies, when we talk about infertility, we always turn our heads looking at the women. And this is the good platform for you to debunk this misconception. Why is it that always females are associated with infertility?
Okay, so it's a myth that needs to be debunked.
Yeah.
When we talk about infertility and the focus is solely on the woman, yeah. We know that it takes two to achieve a pregnancy.
Exactly.
Maybe except for Mary, who was able to
yeah.
Conceive without a man. Yeah. But even that one, the Holy Spirit was there. So yeah. Men contribute significantly to fertility. Mm-hmm. It's been shown that about 40 to 50% of infertility is contributed either directly by the man or together with the woman. So 40 to 50%, that's about half of infertility cases, the man contributes to it. So men really are important when it comes to managing fertility. And as part of that, it's important that we start with the men from the beginning. There are times when a woman will come to you, you ask, where is your partner? I say, oh, the partner said I should come and then start first. Mm-hmm. Or I should come and check whether there is a problem with me. As for him, he doesn't have any problem. So it's important that we start with the two early enough. And interestingly, most of the issues with men are more easily treatable. Okay. So if the issue is with the man and the woman comes, you will do all your treatments and you will not be able to be successful. But once the man comes, sometimes you may not even need to treat the woman. Yeah. Okay.
Thank you very much for debunking this. And so to our viewers, you know, just like as you heard, 40% of infertility cases are associated with men. So when it comes to that situation, it's very, I mean, it's important or useful that both couples go and see the doctors. Now, Doc, how common, talking about, how common is men associated with infertility? How common is it?
Oh, okay. So it's quite common. As I've mentioned, about 40 to 50% of infertility is contributed by men. And then also, when you look at men, it's been shown globally that 1 out of 10 men have fertility issues.
Okay, all right. And you also in your submissions, you made mention of some of the causes or risk factors associated with infertility. You made mention of age as considered when you come. It's one of the things you consider to determine or classify somebody as infertility. But let's look at the causes. What actually causes, both the men and female and women, what causes infertility?
Okay, so infertility, as you talked about, I'll classify them into men and then women. Yeah. And then there's also a big chunk which we call unexplained infertility. Okay. So I'll talk about that too. So with the men, sometimes infertility, you know, for the man, the main thing that the man contributes is the sperm. Yeah. And the sperm is produced from the testes. But sometimes things that happen before the testes can lead to infertility, or things happening at the level of the testes, or even after the sperm is produced. Okay. So hormonal imbalances, for instance. So for men, before sperm is produced, some hormones need to be released. Sometimes maybe a man is not producing a particular hormone or is overproducing some hormones. And this can lead to infertility. Then also, we also see men who take exogenous hormones, sometimes for to maintain their body physique, exercise and all that. Usually it's testosterone, and this can affect their sperm counts severely. Okay. Then also, talking about the level of the testes, we have men who have what we call undescended testes. We call it cryptorchidism. Yeah. So the testes, the sac is empty. There's no testes in it, which means that usually the testes is migrates from the abdomen down. So sometimes it may have stopped anywhere along that tract. And once it's there, it will not be able to produce sperm because the testis is down and outside the body because of the temperature. Okay. Needed to produce sperm, which is lower than the temperature required, the body temperature. So the testis is usually outside the body,
Yeah.
so or hanging from the body to be able to get that optimum temperature. So if the testis is at these locations, these abnormal locations, they will not be able to produce the sperm. Then also some infections, so like mumps orchitis. So mumps infection affecting children.
Okay.
It can go to the testis and then damage the testis. Then also sometimes trauma. Maybe there's been a trauma, somebody has kicked the lower part of the child, is swollen, and the testis becomes damaged. That can also affect fertility. Then also sometimes some genetic abnormalities.
Okay.
So there are people who, even though they are men, their genetic material, there are some differences. Sometimes some chromosomes, there's some deletions in them, something that should be there, which will help production of the sperm is not there. And then also, so generally that is at the level of the testis. Another important thing too is temperature. Okay. As I mentioned earlier, there are men who, by the work they do, they go very close to heat, or where they sit, there's a lot of heat. Even it's been shown that even having a laptop on your laps for a long time, the heat that it generates can affect the sperm production. Then also, sometimes after the sperm is produced, the sperm needs to be transported to the tip of the penis and into the vagina. Okay. Sometimes the tube that transports this can be blocked. We call it vas deferens. It can be blocked through infections. Okay. And then also, in some men, it may not even be present at all. We call it congenital absence of the vas. They don't have the tube at all. So they will not be able to, even though they may produce the sperm normally, they may not be able to transport the sperm. For the woman,
but before you go to the women, I have quite a number of questions to ask related to the men. You made mention of the sperm, you made mention of the testicles as well as the tube transporting the sperm. Let's come to the sperm. Does the quantity of sperm you produce also have some influence in terms of fertility or infertility? Okay. That's my first question. And then when it comes to the tube, is it not the same tube they wee through, or is quite different? I want to know. So in this case, if somebody does not have that tube, does that mean the person doesn't wee at all? And the third question is the location of the testicle. So does that mean maybe there's one testicle in the sac and then the other one is tucked in the abdomen? Does that also, can the person produce sperm or be fertile? Yeah. So these three questions.
Okay. So first you asked about the quantity of the sperm. Yeah. So all the things I talked about, that's the things that are happening before the testis, at the level of the testis and after the testis. They can affect the sperm in different ways. Okay. So sometimes the quantity may reduce. We call it oligospermia. There are times that there may not even be any sperm at all. We call it azoospermia. Then also, it can also affect the shape of the sperm. Okay. So sometimes the sperm, which should have a head, a middle piece, and then a long tail, may have a very big head, or may not even have a tail, or may have two heads. Or sometimes the middle piece is so huge. Okay. When that happens, the sperm is not able to swim the way it should, and it's not able to fertilize the egg. Yeah. Then also the motility, that's the movement of the sperm. So that is also important. So it can affect the motility of the sperm. Sometimes instead of the sperm moving in a progressive forward motion, they are moving circular. Okay. Or they are just moving anyhow. They are not progressing. Yeah. So we look at all that. Okay. And sometimes too, you may have the sperm, everything looks well with the sperm, but the function of the sperm itself, it will be able to get to the egg, but it's not able to penetrate the egg. Yeah. So the sperm function may be gone. Yeah. So these are the things that can affect. So the quantity is very, very important. Okay. Because yes, they have to swim through the vagina, through the uterus, through the tubes before they are able to get to the egg. Yeah. So you need a good number. Yeah. And it's even been shown that we even at the level of the egg, you still need more than one sperm to help create the way for the final sperm that will enter. Okay. So that is for the first question. And then the second question,
whether the tube is the same as where the
so when sperm is produced, it goes into the epididymis, which is the storage place. Okay. After that, there's a tube that carries it. We call it the vas deferens. Okay. This tube that carries it then goes to join the urethra. Okay. So at the level of the urethra is where the urine comes through. So it's like you having one road and then another road coming to join. So the man will be able to urinate, but the sperm will not be getting into the will not be getting into the urethra to come out. And a few times too, what happens is that instead of the sperm coming into the urethra and coming out, it rather goes and then enters the bladder. So we call it retrograde ejaculation. So the man ejaculates, but instead of the sperm coming out of the body, the sperm enters the bladder. So that can also
and then with the one testicle and the other one stabbed in the abdomen.
So if you have one you need two. That's why God gave every man two. So if you have one, it will be able to function. But let's assume that you need 20 million and 10 million is being produced by the left side and 10 by the other side. So if one is not there, you end up with 10. Okay. But there are men who may have very good counts. I've had men, usually the normal sperm count is around 16 to 20 million per male. I've had men whose sperm count is in the 200s, 298, even 300. Once it goes beyond that, it's abnormal. But you have men who have very high numbers. So for a man like that, if one testicle is down and the other one is up, the person will be able to still father a child. But the testicle that is in the abdomen can undergo changes, malignancy. So it still needs to be worked on. Okay.
Now let's move to the females, their causes.
Okay, so with the female, we group it under ovulatory problems, and then tubal problems, uterine problem, and then cervical problems. So with the ovulatory problems, most of the time before a woman ovulates, there are hormones that are produced by the body, from the brain, from the pituitary, from the ovaries, which facilitate this ovulation. If there's an abnormality with any of these hormones, either it is not present, it is absent, or it's reduced, or it's in excess, you may have problems with ovulation. One important condition that can cause this is what we call PCOS, polycystic ovarian syndrome. In this syndrome, what happens is that the woman tends to have more male hormones. So every woman has some male hormones which is converted to estrogen. But sometimes this male hormone is not converted to estrogen. And because it's not converted, it accumulates and it affects ovulation. There are also women who have reduced ovarian reserve. So before a woman is born, the number of eggs that woman is supposed to have is already there, sealed. And this number decreases drastically as you grow older. So there are women who lose at a faster rate or start with a very low number. So most people, by the time you are 50, 45, after 40 years, that's when we expect that the numbers should go down. But for some people, by the time they are 24, 30 years, the number is finished. And when that happens, they may have difficulty conceiving. Then also, we have tubal factors. In fact, in Africa, it's one of the commonest causes. And this can happen when the tube is blocked. It may be one side or two sides, but most of the time when the two are blocked, that's when fertility becomes a problem. And it can occur due to infections like gonorrhea, chlamydia, Sometimes women can get what we call pelvic inflammatory disease. This can also cause adhesions between the tubes, and that can destroy the tubes or cause blockage of the tubes. Sometimes if a woman has had surgery, abdominal surgery or lower abdominal surgery, multiple of them, that can also cause tubal problems. Sometimes genetically the tube may be abnormal. Okay. And then also when it comes to the uterus, fibroids, even though not all fibroids cause infertility, depending on where the fibroid is located and the size of the fibroid, sometimes it can also lead to infertility. Then a condition we call adenomyosis, where it's not like fibroid, but the whole uterus has become very hard. This can also affect fertility. Sometimes the cervical secretions can be hostile to the sperm. So instead of it receiving the sperm and then transporting it up, it destroys the sperm. It contains factors that will destroy the sperm or prevent the sperm from being effective. And this can also affect fertility. And then the unexplained, this one is also very common. What happens is about 10 to 15% of cases. You've done all the tests, everything seems normal, but the woman is not able to conceive. And this is what we call unexplained infertility.
Okay. All right, thank you very much. You see, there are a lot of causes associated with infertility, and this actually proves and shows that we have to continuously talk about infertility so people are aware. This is just the medical aspects, but when we come to the environmental, lifestyles and all that, I'm sure there are lots of causes which you will talk about it after this short break. So we'll go for a break. When we come back, we'll continue the discussion. Please stay tuned. We'll be right back.
Explore a whole new world of exciting visuals with AAU TV. Get ready for a mix of interesting talk shows, interviews, discovery documentaries, and news on AAU TV. It's not just about watching TV, it's about experiencing something special. AAU TV reaches over 25 countries in Africa, bringing you a blend of knowledge and fun. Learn about different cultures as you enjoy the shows. If you have events or want to showcase your business, we've got you covered. Watch AAU TV free-to-air channel on satellite. Connect with us on Facebook, Instagram, and X, formerly known as Twitter, at AAU TV. Reach out on call or WhatsApp us at +233 26 629 6601 or +233 20 399 5210. AAU TV, the voice of higher education in Africa.
You're welcome back from the break, and thank you for sticking with us. This is Meet the Practitioners on HealthAfrik, and today we are discussing fertility and infertility. Before the break, we got to know what actually it is from the medical perspective, as well as the causes influencing it. And we are here with Dr. Seth Hansen-Gershon from Kolebu Teaching Hospital. Hello, Doc.
Yeah,
Thank you
hello.
for sticking with us. So like I mentioned before the break, you made mention of some of the causes of infertility. I know what you mentioned were the medical aspects and the genetics and all that in terms of the body, but I know there are some things that also influence, like some factors like environmental factors, societal factors, and even lifestyles. So briefly tell us some of these that also influences infertility.
Okay, so when we take, for instance, lifestyle, things like smoking, excessive alcohol intake can affect sperm quality. It can also affect the woman when it comes to conception. Then also things like obesity, stress, and it's one of the problems. I mean, sometimes people with infertility tend to be stressed, and they get stressed from society and all that, and that even compounds the problem.
Okay.
And then also when it comes to environmental, exposure to environmental toxins, chemicals, pesticides, all this has been shown to affect fertility. Some plastics have been associated, Sometimes you sit in your car, maybe it's been in the sun for a long time, and the plastics that are in, you sit in it, there's so much heat.
Yeah.
You have to open the windows for this heat to escape. Some of these things can affect the body. Radiation, now we have masks and all those things. The radiations can also affect the man. It can also affect the woman.
Okay, right, thank you very much. So in your submission, you made us understand how an individual is classified as infertile, like not being able to give or bear a child. Now, an audience listening to us, or a viewer listening to us, watching us, may be associated to that and should come to you. What are the steps to diagnose the person, or to know whether the person is infertile, or maybe it's something that is showing those symptoms? Yeah.
Okay, so by what we talked about, infertility is diagnosed clinically.
Okay.
So if somebody comes and the person has not been able to conceive after 12 months of unprotected regular intercourse, we can say that she has infertility problem. Okay. It's important to mention here that infertility can be primary or secondary. So primary means that the woman has not conceived ever in her lifetime. Okay. And then also the secondary means that she has conceived before. Yeah. Or given birth before. But at least once she's conceived before, irrespective of the outcome of that pregnancy, if she's trying to conceive and she's not been able to conceive again, then that's secondary infertility. Okay. So when a woman comes and you need to diagnose the woman, or I mean when the couple comes, as I mentioned earlier, it's the couple thing. So you look at both of them. So initially we take a history, a comprehensive history. Okay. Sometimes it may look as if the doctor is prying too much into your life, but it's all important. There are so many questions that we may need to ask. Then after that, we want to examine the woman thoroughly from head to toe. The man too will need to be examined, and then we run some investigations. For the woman, these investigations may include hormonal assessment. We do a number of different hormones to check, and then we also do tests to check the egg reserve that the woman has. We also have tests to check the uterus. So with the uterus, we are interested in whether there are fibroids, there are the cavity, even the cavity of the uterus. There are tests that we use, like hysteroscopy, to look inside the cavity to see whether there are adhesions, sometimes some infections, or previous, a woman who has had a termination of pregnancy surgically, or can have some adhesions in the uterus, which can prevent pregnancy or implantation of the fetus. Okay. So this is some of the tests that we do for the woman. And then we also do a tubal assessment. So we check whether the tubes are patent. Okay. Because the tubes need to be patent for conception to occur. And to do this, there are different tests that we can do. One is called HSG, hysterosalpingogram, which uses X-rays to check, and then a contrast to check the tubes and the cavity. There's also SIS, or saline infusion sonography, which we also use to check. That one uses ultrasound. There's a test known as HICOC. There's also laparoscopy. We call it lap and die. All these things can be used to assess the tube. Okay. Okay.
And then the men?
And then with the men, we also have, first of all, the basic test that we do for the men is semen analysis. So we want to do a test to check whether the semen is adequate, they are looking normal, and they are progressing well. If this is fine, most of the time that ends it. Okay. A few times we may do things like fasting blood sugar to rule out diabetes and all that. But if there are abnormalities with this, we go further to do hormonal assessment of the man. There are times when we have to do genetic assessment and even karyotyping. Karyotyping means that we are checking the actual sex of the man. Even though there's the man is usually the man is XY, but sometimes the man has maybe XXY. Okay. Or the Y is not there, or the Y is diminished. All those things we check them because they can all affect fertility.
Yeah. Great. Now, mentioning the women's diagnostic step, you made mention that you sometimes look at the number of eggs reserved. Would you advise that as a teenager or a lady growing up, it is important to go and know the number of eggs you have at the moment, so you know that maybe you are fertile or infertile? Would you advise that? I've heard that before. I'm asking personal. This is to me. Maybe coming to you to advise me. Do you think it's advisable for me to go and know the number of eggs I have within me now?
Oh, okay. All right. So generally, it may not really be advised that every woman should go checking how many eggs they have. But if you are growing, maybe you are getting into your 30s and you realize that you are not ready to have a child now, maybe you want to have a child after 5 years, then it's important you go and check how much you have, because every year it goes down. So if you are already having a low number, then your 5 years may not be advisable. Or even if you decide to still go for the 5 years, there's an option of freezing what you have. So we can freeze the eggs and keep them there for you. So if you are 30 years and you freeze these eggs, they will be 30 years. Even if you come 40 when you are 40, they will still be age 30. So that is something that can be done. So.
Thank you. Talking about diagnostic, now let's move to treatment. What if I'm diagnosed or classified as infertile? What are some of the things or the treatments available to help me out of this situation?
Okay, so with the treatments available, sometimes just advice. So I've had patients who maybe the man is living in Kumasi, the woman is in Accra. They meet certain times in the month. But most of the time, the times that they meet, that's not the fertility window. So all you need to do is to understand this and then advise them that if they have to meet, they should try and meet around their fertility window. And this alone may be the solution for some people. Others, you may advise them on lifestyle changes and all that, and this alone may work. Some may need some form of treatment. And the treatment can be medical, it can be surgical, or it can even be advanced reproductive treatments. So with the medical treatment, sometimes we give them medication, oral medications that they take. And then we advise them when to have intercourse. We call it ovulation induction and time intercourse. There are people who may need medications, sometimes even some injections. And then we have to do what we call IUI, intrauterine insemination, where we take the sperm from the man, we wash it, and then we put the sperm directly into the woman at a particular time. So that is also something that can be done. Then we also have IVF. IVF is in vitro fertilization. In vitro fertilization means that we take the sperm from the man, and then we retrieve egg from the woman, and then we put them together to fertilize. Once they fertilize, we allow them to grow for a few days, about 3 to 5 days, and then we transfer the embryo into the woman. So that is IVF. Then we also have what we call ICSI. It's similar to IVF, but that one we use it for people who have very low sperm counts. So instead of putting the sperm around the egg for it to fertilize by themselves, we take one sperm, one good quality sperm, and then we inject it directly into the egg. So that one, if you have few, you may still be able to do that. So that is also another procedure that can be done. And then a few people, despite all these options, they may not be able to undertake these options for certain reasons, or they've done it and they are not successful. And in this case, there's what we call surrogacy. So surrogacy means that somebody will carry the pregnancy for you. So we take your egg, we take the partner's sperm, we fertilize it. The woman may not be able to carry it herself, but somebody can carry it for the woman. But it is the woman's genetic material. It is not from the person carrying it. So it's just like a surrogate. The person is just carrying it for. There are people too who may need some help, as in donation. They may need somebody to donate an egg or somebody to donate a sperm for them. So this can also be done.
When you talked about the surrogate, I was about to say this has create issues. I mean, sometimes they'd be like, this is my egg, this is my child and not yours. Although I signed or I understood initially that I'll carry the child for you, but it is also my child. So it becomes a problem, creating issues in terms of who really owns the child. But thanks for clarifying that there are some cases where it is both the man, the biological mother and biological father's eggs that comes together to be placed in someone's womb. Thank you for clarifying that. Now, with this, I know we can talk more about the treatment, which will be for another episode. I know, yes, you would want to hear more of the treatment, but due to time, let's look at some preventive measures that you think we can undertake to ensure that we don't even get closer to being classified as infertile. Yeah.
Okay, so I think from the things that we have talked about, I think this starts even from early life. So you make sure that if your children get infection, you take them to hospital, you treat it quickly enough. Yeah. We've seen that an infection as simple as mumps can lead to orchitis and cause male infertility or even female infertility when it affects the ovaries. So this is one of the ways. And then also lifestyle changes. Alcohol, reducing alcohol, stopping smoking. These days, the women even smoke more than the men. There's what we call shisha. Yeah, and even other forms of things aside nicotine. So that is also there. Obesity, reducing weight, living within a very, a healthy body weight, eating healthy food, and all that can help prevent infertility. And then also infections. Sometimes there are women who may have an infection. Instead of coming to the hospital for medication or to be assessed, they go to the pharmacy, they are giving somebody, they try it doesn't work, they try it, or some use herbal medications and all that. What will happen is that over a long period, the damage to the tube may be irreparable. So it's important that when you have an infection, especially vaginal discharge associated with lower abdominal pain, you need to go to the hospital as quickly as possible so that it can be treated with good antibiotics so that it will be gone, so that at least you will be free from this kind of infections. Okay, so some of these things are things that can be done. And then also avoid things that stresses. And even as a community, we need to support them. Sometimes by putting pressure on them. When is the next baby coming? Or when are you giving birth? We came for the wedding 2 years ago. We are not hearing any child or something. Or sometimes people will even be counseling, oh, don't worry, everything is fine. But already the woman who is not able to conceive is already knows that it's a problem to the person. So you coming to tell the person every time, talking about children and telling the person she shouldn't worry and all that, it may even compound the problem. So we should sometimes just leave them alone. Leave them alone, and in God's time, they will have their babies.
Thank you very much. I'm talking about support. You know, in my introduction, I made mention that in Africa, infertility is a major problem, and this is due to limited access to healthcare facilities. Now, you being in the field, I know you are open or prone to some of the advanced equipment, lab things that are needed to ensure that at least we can address some of these challenges. So this goes to the government. I would want you to talk to the government. What are some of the things or their role they can play to ensure that in Africa we can address infertility like in a very high standard way?
Okay. So in times past, the focus has been on population reduction, so family planning and all that. But there are others too who are not able to even have one. So we have been advocating that there should be we should not shift totally from family planning, but we should also consider those who are not able to have, so that at least policies can be made to help them, creating awareness, setting the pace. And then also we've also realized that sometimes insurance, healthcare, it doesn't really cover people with infertility. So this issue cover both the NHIS and then private insurance, because these people also need help.
Yeah.
And then also training of more fertility specialists. I think government can help in this regard. And then centers where we can be able to give comprehensive care for infertility. In most government facilities now, there are some treatment modalities that cannot be done.
Yeah.
For instance, IVF, sometimes even intrauterine insemination, you cannot do it. But government can take a lead role and then establish centers where some of these procedures can be done. And this will go a long way to help women to, conceive without having to spend a lot of money if government takes the lead.
All right. Thank you very much. Thank you, Dr. Gershon, for your insight. Before we wrap up, share with us your last words to families who are currently battling infertility, especially to the men. They should be there to support them. Yeah.
Okay. All right. So my advice to couples who are trying to achieve pregnancy is that they should seek help early. And as they seek help early, they should also follow their doctor's instructions, and they should continue with the follow-up. And then also I will advise that they should, faith is important, but they should not neglect the science aspect, because that also helps to be able to, for them to be able to conceive. So they should have faith, and then they should have hope. They should never lose hope.
All right. Thank you very much, and we hope to see you again on Meet the Practitioners. It's been so interesting on this topic. And this is the end of today's episode, where we discussed fertility and infertility. And I know you've had a lot of information, you've been educated. Based on today's episode, we've got to know that there are a lot of options when it comes to treatment. So open up, share your problems, and the doctors are there to support you. We are going to have another episode where we will delve deeper into the treatment of infertility as well as management. Yes, and it was a privilege having with us Dr. Seth Hansen Gershon from the Kolebu Teaching Hospital. I know you would want to meet us again in our next episode. My name is Isabella Teta Hinakwa. Do have a good day.